Just to give you a bit of my background, I've worked in oncology in large metro in Melbourne, at Peter Mac for 10 years at Cabrini, Malvern. Then I spent 3 years establishing a national home infusion service for oncology and rare diseases. And then I went to regional Victoria and worked in oncology there. Now I'm the Director of Clinical Service in a small health service that provides chemotherapy 3 days a week. We have visiting oncologists from private and public. I just noticed Leslie's here, and I first encountered oncology in 1991 and at Box Hill in the inpatient ward, and Leslie came in with Nairi to say they were starting the day oncology unit, and I thought, that's what I want to do one day. And she's still there doing it. So my first thing is what we all know, the elements of safety with chemotherapy, and it's not new to anyone here, is that there's either hypervigilance about cytotoxics, or it's just a drug in the line. There's two extremes in how people can approach it. An example of the hypervigilance, I looked after a lady once who was about 55, and her daughter had her first grandchild, and the family wouldn't let the grandmother see the baby for the whole period of her chemotherapy treatment because they were scared of what the cytotoxics might do to the new baby. On the other hand, I've worked in a hospital where a senior member of staff thought I was becoming hysterical about putting parameters around who could administer chemotherapy, and I was told it's just a drug in a line and not to be too worried about it. So in rural areas, there isn't a body of expertise for staff to turn to for advice and daily support and decision making. Our oncologists at Stawell are only there 1 day a week, and out of 3 days that we provide the service. And that doesn't mean we can't provide the service, however, it provides a challenge to ensuring everyone's safety. When a health service decides to provide oncology services, it's essential that there's expert oversight for delivery of every aspect, every facet of the service and the ongoing service delivery. I'm really aware that although day oncology services are provided by small health services, the health executive often don't have an oncology background. In fact, I don't know of many executives who do have that background. And so without that knowledge of the people who are providing the clinical governance, elements of safety can be missed. And also, having survived a number of accreditations over the last 10 years, I'm yet to meet a surveyor with an oncology background, which was actually kind of a nice thing in some ways because you got away with stuff maybe, but what it does highlight to me is that we don't have anyone giving us expert oversight or no one's really giving us in-depth accreditation or overview of our services in oncology. For example, I worked in a hospital where patients were receiving 5-FU via the ambulatory pump, and they were referred to the regional district nursing service to disconnect their pumps, which is fantastic. Patients don't have to head back to the city, they don't have to go back to town to have the disconnect, they can have it done at home, and it saves them an awful lot of time. However, when I looked into it, I discovered that the district nurses didn't have appropriate PPE, and they weren't trained in the management of cytotoxics, and that they didn't have any training in how to assess a patient on day 3 or day 7 after their day of chemotherapy, and I saw that as a significant risk both for the patients and for the staff doing that, because as we know, day 3, day 7, that's when some of their symptoms are starting to appear, and if you don't have the experience to understand what that treatment was on day 1, you might miss things that patients are presenting with on those days later. So I'm going to give you tell you a story about a lady who presented for her first dose of ABVD for Hodgkin's lymphoma. Now, I wasn't sure when I prepared this talk of who exactly my audience was, but now I discovered nearly everyone's an oncology nurse, so I don't need to explain everything so much. So this lady came to us, she'd had a port inserted in theatre by a surgeon a few days earlier. And when our nurses had finished their education, they were unable to get blood return. So they spoke to they looked at there wasn't a radiology report at that point, so they rang the radiologist. They got a very vague, not a very defined, they couldn't tell us where the tip was. They spoke to the surgeon and his registrar, and they were a bit horrified that we're even questioning their expertise, and they said it's fine, go ahead and use it. The oncologist was getting frustrated because we were delaying everything, and they said go ahead as well. As you know, as an oncology nurse, the golden rule is you don't administer if there's no blood return. But there was a lot of pressure on the nurses to go ahead. The treating nurse discussed it with the senior nurse, and they decided to use a peripheral cannula instead until they could be sure of the placement of the tip. Now, central lines do not bleed and they're sluggish, and it's really frustrating when they don't work. This lady was scared. She's just starting her first treatment. She'd had this port put in, she'd had surgery, and she was told she wouldn't have to have a cannula, and we're saying we're going to have to put a cannula in. And we're trying to tell her that now there was a risk that maybe it wasn't where it should be. It held everything up, and often when you do investigate, there's nothing, and all you do is delay the whole process. In 3 hours, you're 3 hours late starting treatment, and it's frustrating for everybody. But the nurses stood their ground. As you know, ABVD protocol includes 2 vesicants, which can cause necrosis and serious damage to tissue if it gets outside the vein. So the patient was treated and she went home, and it wasn't investigated any further. However, she presented with febrile neutropenia within a week and was admitted to intensive care. And it was at this point that it was identified that the catheter had exited the wall of the superior vena cava and the tip was sitting in the pericardium. If the nurses had gone ahead, you wouldn't be hearing about it from me for the first time today. I'm sure you would have heard about it beforehand. This is a rare complication, but one with extremely serious consequences. And my point here is that it's the significance of having an experienced nurse beside that patient administering that treatment. Without that experience and that knowledge of the risk that was going to occur, things could have been very different. And it demonstrates the importance not only of education, but of the experience of chemotherapy and the awareness of possible complications. I haven't administered chemotherapy for 2 years now, and although I've done it for a lot of the time in my career, I'm really aware that there's a lot I've forgotten in those 2 years, and 2, there are a lot of new drugs and changes to how treatments are delivered. So if I were to apply for a job in a chemotherapy unit today, what would be the standard requirements for me to start treating patients again? How can we be sure, even with my past, that I can safely treat patients in a small hospital without experienced oncology staff who will oversee my clinical skills? If a small health service decides to establish a new oncology service, how much experience do nurses need on completion of ADAC before starting to work alone in a new oncology service? And who's watching this? My belief is ADAC is just the first step in training to deliver chemotherapy. I think it's just the first tip, getting that knowledge, the experience that you need to get, and along the way is significant. But we don't actually say how much experience is enough. And in services that operate 1 day a week, and especially in a new service where you're not giving a lot of chemotherapy, how do we maintain the nurses' skills? And how do they gain the experience they need to identify complications that can occur? There's another thing, and these are just examples of things that I've encountered in oncology units as I've worked in them. And these are some examples of what I've discovered of when there's things that you don't know, and then we're going along happily, and it's not until someone tells you that something's happened. So in one health service I worked, I discovered that the chemotherapy gowns the nurses were wearing, although purple, were not cytotoxic safe. They didn't provide the safety to the nurses that they needed. I also discovered that the dose reductions for chemotherapy were being administered via a burette with an air vent. So I was going to explain what a dose reduction was, but I don't think I need to now. So the dose reduction was going through a burette with an air vent, so that was then putting nurses at risk of aerosol contamination from the chemotherapy. As you know, chemotherapy should be administered in a closed IV system, and this system didn't support that. Another thing I've discovered was that cytotoxic waste was not being disposed of correctly. Some of it was going into the general waste. So it upset the hospitality services, but I recommended a change to how we managed our waste, and the cost of cytotoxic waste went up considerably, but it was a necessary change to keep our patients safe, our staff safe. Another thing I've encountered where I'm working at the moment is the credentialing of medical oncologists. So it's an area which needs on-site oversight by specialist oncologists, and in our oncology committee in our health service, people weren't aware that medical oncology was a different specialty to haematology and to malignant malignant haematology. So we had services being delivered, all those services being delivered at our health service. So we invited the head of medical oncology from our regional centre to come and sit on our credentialing panel to overview that. And then after he had reviewed the qualifications of the staff, I went back and had a look at what our doctors were prescribing to see that if that was aligned with it. And I'm not sure that we have that in-depth knowledge. I know that if there was an endocrinologist doing services, I wouldn't pick up that there was any difference there. It's not my area, I know. But in oncology, we need to make sure that the oncologists prescribing are qualified to be prescribing what they're doing. So IT and safety in oncology, and I'm really pleased to see that it's been well supported by what the things that people have spoken about today. And anyone who's worked with me in the past will know how passionate I've been about oncology prescribing systems. So a challenge in rural health services, and I guess there was a lot of people who put up their hand earlier who said that their chemo's still being ordered and handwritten, is to provide the oversight for treatments being prescribed and the challenge to ensure evidence-based treatments are followed as outlined by COSA that we've just heard about today. This is really difficult to achieve in a rural health setting, given that there are well over 400 treatments available, and that doesn't count clinical trials. Pharmacists in small rural health usually don't have an oncology background, and in a small team, it's difficult to recognise that a treatment is outside acceptable protocols or to question a doctor's prescription. Really challenging for staff working in that space. The most effective tool that I've encountered to support monitoring is the use of electronic prescribing systems such as Charm, ARIA and Mosaic, though I'm not a fan of ARIA, just so you know. It's too hard. In one hospital I worked where Charm was introduced, it became clearly evident when a prescriber was not prescribing either the recommended dose or was deviating from a treatment protocol. It was identified that someone was prescribing 9% of the recommended dose on a regular basis. Policies and procedures were put in place so that medical staff who wished to prescribe on an alternative were required to provide evidence of research in support of the variation for the peer review prior to going ahead with that treatment. And Charm, which was the system being used in this case, was clearly demonstrate that to anyone who was giving that drug that this was different and that they needed to check what was happening. Electronic oncology systems not only provide parameters for drug doses, but also provide guidelines for administration, compatible fluids and rates, blood count parameters, recommended antiemetics, etc. It provides a really good structure for us to work in. Significant guardrails around the treatment, supporting doctors, nurses and pharmacists. In small services where some treatments are provided infrequently, these guidelines are invaluable. However, as it's already been identified today, in a small rural health service, electronic systems are really expensive, and not only expensive, they're hard work to maintain. They need significant resources to maintain those protocols and keep them up to date. We have the 2007 Clinical Excellence in Cancer Care, a model for the safety and quality in Victorian Cancer Services, providing a framework for cancer services. Our challenge is to adapt this to the rural and regional setting, where the responsibility for the oversight of oncology services in a hospital is a hospital executive, usually don't have an oncology background. The delivery of anti-neoplastic therapies, in the delivery we need to ensure that we have adequate informed governance in the provision of care. Treating patients remotely and close to home is absolutely what we want to strive for, but we want to ensure that we are providing this care safely by informed oncology staff and that we have robust clinical governance structures in place to ensure that all elements of care have been carefully considered and that we have clear and considered standards in place. None of the examples I provided earlier before are insurmountable. None of them are the reasons to withdraw services from rural and regional areas or even from home. We just need to make sure the right checks and balances are in place. Some of the things we've put in place where I work is that a complete suite of education through EverQ modules and demonstrated clinical practices in place, blood-safe e-learning modules prior to administering treatment. They must be completed before a nurse starts. A nurse new to the oncology unit must work for at least 6 months with a senior nurse in day oncology. Nurses have to complete the reassessment every year. Oh, I'm going too slowly. Nurses are encouraged to rotate through regional and metropolitan services to gain experience and exposure to new treatments and therapies. I'm going to skip across because Bob got up and I'm worried I'm going to run out of time. We also have a regional oncology nurse practitioner who provides oversight for the chemotherapy administration and provides nursing education. The head of medical oncology, as I mentioned before, oversees the credentialing of our oncologists. Our pharmacist is provided support by the regional oncology pharmacist, and they are required to complete a number of the EverQ modules. And our hospital and administration staff also manage the handling of cytotoxic waste. So my recommendation is that for rural oncology services, that we invite oncology specialists to come in and review every aspect of our service provision, and that it's reviewed every few years to make sure that we're staying on track, maybe an oncology accreditation, and that I would love to see as a state that we introduce an electronic oncology system for all services to access. As an oncology community working in regional and rural health, we need to have an agreed position so that if health service does decide to provide cancer services in the community, they are provided with clear guidelines and the elements needed to provide safe care.
Robyn, thank you very much. It's a really nice review of the system, and I'm so pleased to see the good work you're doing at Stall. We are running really short on time. We have a few questions here. Is there anyone who wants to put their hand up and ask a question from the audience? If not, I'm going to just, because it's such an important topic, I really do think that this issue of how we provide care in the regional areas is so important. I've got lots of questions. One is there a role for staff rotating through rural centres? In other words, do you have a system where you can send them from Stall down to Ballarat, or from Ballarat to Peter MacCallum, or whatever?
Yep. And one of the things I introduced at one of the hospitals was that the ward staff who gave chemo infrequently, that they rotated through day oncology, because I think they need to maintain their skills. They need to spend a number of months every year keeping that up to date.
So these things are good. My final question is, what do you see the role of telehealth? Do you see telehealth having a role here?
Yeah, I mean, Queensland have got that up and running and in that support. So I think there's definitely an opportunity for that. Yep, absolutely.
Okay. Robyn, thanks very much. We could talk on, but we must move on.